Hi everyone, I am Dr. Soumen Das. I am heading the Surgical Oncology Department of Netaji Subhash Chandra Bose Cancer Hospital. Today I am here to discuss few very basic topic of surgical examination, be it undergraduate examination, be it MS or DNB final examination, and in your day-to-day practice, what basic thing you require is a proper history taking. Now, whenever you document a case as a short case or a long case, you need to have certain formulation, certain format based on which you will take the history and you will do the clinical examination. So, what are the format and what are the headings on based on which you will take your surgical case? The first thing is your history taking. Okay, so for any case to be reported, you need to have a good history taking. Okay, and this history taking is actually the information which you gather from your patient is transferred in a scientific manner to a scientific forum. So that's what is known as history taking. I'll come to the details of history taking. Then the next step is general survey. Then come to the examination, that is the local examination, systemic examination. Then you write, after you complete this part is for your diagnosis, history taking to systemic examination, and then summarize the whole case. Okay, so start with history taking, then do a general survey, then do a local examination, do a proper systemic examination. Now you summarize your whole case and give a provisional diagnosis. Now, provisional diagnosis might not be the actual diagnosis, but your provisional diagnosis should be based on the history which you have taken and the clinical examination which you have done. Then you need to suggest some differential diagnosis also, okay? Because your provisional diagnosis sometimes may not be correct. So you need to add few differential diagnoses. And to establish your diagnosis, you need to do certain investigations, and that completes your pro forma of history taking and clinical examination. All right, now what are the different parts of history taking? It starts from number one, patient particulars. Okay, you starts from patient particulars, which has got several fixed format of patient particulars. What are the things which we include in patient particulars? Then you come to chief complaints. Now, what are chief complaints? Chief complaints are those complaints for which the patient has come to you. Okay, it may be one, it may be two, it may be multiple. Now, history of present illness. What is history of present illness? History of present illness is nothing but the elaboration of the chief complaints. And to achieve a diagnosis, to come to a diagnosis, you need to understand that there might be some positive symptoms in favor of your diagnosis. So you need to include those positive symptoms in the history of present illness, as well as the important negative symptoms you need to rule out. Then you come to the past history, then family history, treatment history, history of allergy, immunization and drug history. Okay, so these are included in history taking. So to repeat again, patient particulars, chief complaints, history of present illness, past history, family history, treatment history, and history of allergy, immunization or drug history. All right, now in patient particulars, what you have name, age, sex, religion, address, occupation, date of admission or date of examination, bed number or MR number. Now you see, let us come one by one. Name. Why the name is important? Each and every point has got some importance, clinical importance. Why the name is important? You need to understand that the name not only indicates the identification, but also you can see what is the religion of that patient from the name only. Okay, and you need to address the patient. Whenever you go to examine the patient, you need to address the patient, Mr. Such and such, I'm going to examine you. Okay, so that address you need to make. Next is age. Now age is very important. Why? Because age is very important because there are certain diseases which are congenital. and there are certain diseases which are acquired. Okay, and we know there are several diseases. With the increase in the age, the diseases also, the risk of the diseases will increase. Just like breast carcinoma, age is an independent risk factor. All right, then comes the sex. Why the sex is important? Because there are certain diseases which are prevalent in males, there are certain diseases which are prevalent in females. Then you come to religion. Why the religion is important? The religion is important because there are certain diseases which are common in a specific religion or a specific group of people. And if we take the example of one cancer, that is carcinoma penis, it is almost absent in Jews and it's very rare in Muslims, because in both the cases, in Jews the circumcision is done at birth, so they are protected from penile carcinoma from to happen. Okay, now the address. Why the address is important? Address is important because there are certain diseases which are prevalent in certain areas, like the Gangetic belt of India. There gallbladder cancer is very prevalent. Okay, GB cancer. You have sub-Himalayan areas where the thyromegaly or thyroid goiter is very common. So address is important. Not only that, whenever you are planning a therapy for the patient, you need to know how far the patient is staying. If the address is far away, so you may have to plan certain things which will help the patient to take the treatment over there and go back to their own places. So the distance from hospital and the patient's residence is also important. Next comes the occupation. Why the occupation is important? Occupation is important because there are certain diseases which are prevalent in certain individuals, like varicose vein. Varicose vein is very common in patients who stands for prolonged period, like the policemen, like the shopkeepers. Okay, like the surgeons who used to stand for a prolonged period of time. Okay, and there are some occupational hazards also, like aniline dye workers. Aniline dye workers are prone to develop carcinoma urinary bladder. Date of admission, date of examination, and bed number, because date of admission and date of examination are sometimes different. You need to mention those two things. And if you have the bed number available with you, write the bed number of the patient or the MR number, because later on the communications will be made based on these two only. Okay, now chief complaints. Coming to chief complaints, what do you mean by chief complaint? Chief complaint is something with which the patient has come to you, Okay, now there can be single, there can be multiple chief complaints. Okay, now how do you write them? You write them in chronological order. Okay, in chronological order. Suppose a patient complains of pain abdomen for last 2 months and yellowish discoloration of skin and mucous membrane for 1 month. So you write the pain abdomen first, then you write the yellowish discoloration. Now when the duration of the symptom is fixed or same for two symptoms, then you write based on the severity. You write the first one which is more severe, then you write the second one which is less severe. Okay, so based on chronology and based on severity. So these are the ways by which you write the chief complaint. Now remember, chief complaint is to be written in patient's language. Don't write patient is complaining of jaundice. Write yellowish discoloration of skin and mucous membrane for last 1 or 2 months or like that. Okay, so that's how you write chief complaint. So they are to be written on chronological order. If the chronology is same, then you write based on the severity. Okay, now history of present illness. What is history of present illness? In history of present illness, you need to write certain paragraphs. Number 1 is the elaboration of chief complaint. Number 2, important positive and negative history. Number 3, systemic symptoms. All right, now let us discuss. So elaboration of chief complaint means in first paragraph you need to elaborate the chief complaint number 1. Suppose the patient complains of pain, then you need to elaborate the pain. In paragraph number 2 you need to elaborate the chief complaint number 2. Am I clear? Now if you suspect a particular disease, for that particular disease you need to gather some positive finding or positive history, you need to gather some negative history also. Okay, you in next paragraph you include those two, positive and negative finding. Suppose you deal with a patient with breast cancer. Now you need to see whether this breast cancer has metastasized to lung, has metastasized to other organ or not. To identify this, you need to have a proper systemic symptom evaluation. So in number 3, what you include? You include a systemic symptoms like cardiovascular system, right? Like neurological system, like respiratory system, GI tract and genitourinary tract and musculoskeletal system. So you ask leading questions. Here you ask leading questions like whether you have any respiratory distress, shortness of breath, you have any hemoptysis or not, is there any history of sudden unconsciousness, severe headache, vomiting, is there any history of pain abdomen, is there any history of yellowish discoloration, is there any history of urinary problems, hematuria, etc., etc. So history of present illness means elaboration of chief complaints. If there is one chief complaint, then you write one paragraph for the chief complaint. If you are suspecting a specific disease based on the chief complaint, then you include the important positive and negative history. Then you do a systemic symptoms. If you write systemic symptoms for each and every case, then you are not going to miss any symptom. All right, so that is what is all about the history. Now one important symptom or chief complaint in surgical patient is pain. Another one is swelling. So in pain, what are the important features we need to look into? That I'll discuss. The first is the site, then onset, severity, duration, progress, then the nature. Okay, so site, it is very important. Where did the pain start? Is it in the abdomen? If it is in the abdomen, then which quadrant or which region of the abdomen? Onset, how did it start? Now onset can be sudden, onset can be insidious. Sudden onset indicates that the patient feels the pain started suddenly. That means it is either traumatic or it is inflammatory. Okay, if the onset is insidious, this can be many, because the patient actually cannot recall when did the pain start. Then the severity, is it mild, moderate or severe? What is the nature? There are different natures of the pain, like dalaching, burning, scalding, shooting. This shooting pain, stabbing pain, these are usually neurological pain, the stimulation of nerve endings. Constricting pain is usually seen in cardiac patients, or due to AMI, patient feels pain, constricting pain in the chest. Colicky pain is something which appears to disappear. There is a sudden crampy pain inside the abdomen, then it disappears. Patient remains pain-free for 3, 4, 5 minutes, even 1 hour. Then the pain reappears. So this is called colicky pain. Then duration. How long the patient is suffering from pain? Is it from 1 month, 2 months or 3 months? Then comes the progress. Now the progress can be gradually increasing, it can be static, or it can be the patient has a static pain, then it has increased suddenly. So these are the 3 modalities of progress. One is gradually increasing, one is static pain, the pain remains same for a long duration. Another one is the pain remained same or static for a long duration of time, then it is increasing. Periodicity. Periodicity means patient has pain, then the pain is relieved, patient remains pain-free for 1 to 2 weeks, 3 weeks, 4 weeks, then the pain reappears again, then it disappears, patient remains pain free for a long time, again it reappears. So this is called periodicity. This is very commonly seen in peptic ulcer disease patients. What happens in peptic ulcer disease, there is a healing. Either the patients take some PPI or etc., the or lifestyle modification, dietary habit changes, there is healing of the peptic ulcer disease, and the patient pain disappears. Once again, when the ulceration occurs, the pain reappears. So this is known as periodicity. Time of occurrence, some types of pain has a typical time of occurrence. It has been seen the pain of appendicitis starts usually in the morning after micturition. Now, the more important thing is aggravating factors and relieving factors. You need to know what are the aggravating factors of the pain and what are the relieving factors of the pain. Say, for example, in duodenal ulcer, what happens? Prolonged fasting is associated with aggravation of the pain. Okay, and relieving factor, if the patient takes food, the pain is relieved. All right, but in peptic ulcer disease or in gastric ulcer disease, the food intake will increase the pain. In cholecystitis or gallbladder related pain, when the patient takes fatty food, the pain increases. So these are all aggravating and relieving factors. Remember, in pancreatitis, when the patient stoops forwards, sits and stoops forwards, the pain is relieved. So these are all aggravating or relieving factor. By knowing this, you are actually trying to identify what is the disease the patient suffering from. Then associated symptoms. Now associated symptoms are important because there are some symptoms which accompanies the pain, like in pain abdomen, if it is associated with abdominal distension, if it is associated with vomiting, if it is associated with constipation, then it goes in favor of intestinal obstruction. Pain, vomiting, abdominal distension, and constipation. All right. Then one important thing is the movement of pain. There are three important terminologies. One is radiation, another one is refer, another one is migration. Radiation means there is pain at the primary site, there is pain at the secondary site. Okay, like if the pain is felt at the primary area, that is for duodenal ulcer, patient feels pain in the epigastrium. When there is some extension of the ulceration into the posterior wall, patient feels pain at the back also. So at one time, patient will have pain in epigastrium as well as at the back. So this is called radiation. So the duodenal ulcer pain now radiates towards the back. All right. Referral of pain. Referral of pain means patient does not feel in pain at the primary site where the pain is originating, but the patient is felt at the secondary site. Like if you have any irritation of diaphragm, subdiaphragmatic abscess, hepatitis, or any irritation of diaphragm, patient feels pain at the shoulder. There is no pain at the primary site, but due to the same dermatomal supply, the patient is felt at a distant site. This is called referral. Migration of pain means patient initially feels pain at one site, then the primary site or the first site pain disappears, and now pain reappears at the secondary site. This typically happens in acute appendicitis. What happens in appendicitis? Initially, there is stretching or inflammation of the visceral peritoneum. And we know appendix is supplied by the same dermatome, that is the T10. Now, patient feels pain in the periumbilical area. So, at the initial phase of acute appendicitis, patient feels pain in the periumbilical area. Gradually, when the inflammation progresses, patient now has an inflammation extending up to the parietal peritoneum or the right iliac fossa of the abdomen. Then the patient is felt at the McBurney's point or the right iliac fossa of the abdomen. So this is called migration of the pain. So these three is important. Radiation means there will be pain at the primary site as well as pain at the secondary site. Referral means there is no pain at the origin of the pain, but the pain is felt at a distant site. This is called referral. And migration of the pain means patient will have pain at a site, then the pain migrates to a different site, and the primary site now there is no pain at the first site. Okay, am I clear? Fine. Now another important history is history of swelling, because in surgery majority of cases will present with swelling. What are the histories you need to include what in your history of present illness section for the swelling. Now this can be any damn swelling in the body, be it a breast lump, be it a thyroid lump, be it an abdominal mass, whatever it is. You need to include all these points. First of all is number. How many swellings are there? Is it single? Is it multiple? Site, where exactly the swelling is. Now when you are describing in patient's language, you need to mention the area in patient's language. But when you are writing your history at your history of present illness and during the examination, you need to mention the site in scientific language. Okay. Onset, how did it start? I told you it can be a sudden onset. Now it can be an insidious onset, just like pain. Now sudden onset always indicates a traumatic swelling. A patient pushes here, the patient falls, there is a swelling. So this is a hematoma or a traumatic swelling, or an inflammatory swelling. There is some bite, there is some injury leading to inflammation. So if you have a sudden onset swelling, it usually goes in favor of an inflammatory or a traumatic origin. Duration, how long the swelling is there. Is it for 1 year, 1 month, 2 months? Is it for 2 years? Is it for long 20 years? What is the importance of knowing a duration? Because if the patient has a small duration swelling but increasing very rapidly, a large swelling, it indicates that the swelling can be a malignant one. Whereas a long standing swelling, 20, 30 years or 10 years, without any much increase in the size, goes in favor of a benign disease. Because end of your history taking, what is your aim? Your aim is to come to a diagnosis. Okay. Progress. Now the progress can be a static, the swelling is not increasing. It can be gradually increasing in size, or it can be static for some time. Now over last 1 to 2 months there is increase in size. Now all these three are important. This first one goes in favor of benign. The second one can be benign, can be malignant. Alright. And this third one, where there is initially it looks like benign, then there is malignant transformation. Say for example a parotid swelling. Patient gives you a history of a long-standing parotid swelling, but for last 2 to 3 months the swelling has increased suddenly. So that means it had a benign course initially. Now it has increased in size, either a hemorrhagic degeneration or there is malignant transformation. Again, the aggravating and relieving factors are very important. What are the factors that increases the swelling? What are the factors that causes reduction in the size of the swelling? Now if you look at hernia, any hernia inside the body. So what is hernia? It's a protrusion of the contents to the wall of its containing cavity. Alright. Now if you increase the cavity pressure, automatically the hernia swells up. So any hernia swelling will be increased in when you increase the pressure of the cavity. For abdominal hernias, if you increase the abdominal pressure by cuffing, by leg raising and etc., you will find the hernia is increasing in size. Okay. And when the patient lies down, the abdominal pressure goes down, the swelling disappears or swelling reduces in size. Okay. Associated symptoms. If the swelling is associated with severe pain, fever and etc., that goes in favor of a inflammatory variety. Okay. So this pain and other associated symptoms are very important. Recurrence of swelling. Are you dealing with a recurrent swelling? Suppose a patient has a swelling in hand or in the inguinal region. During examination, you will ask the patient whether your swelling is very recent or you had a swelling in that same area. So if the patient says that I had a swelling, I got it operated, now it has come again, so you are dealing with a recurrent swelling. While you examine during your inspection, you will find there is a scar mark there. Okay. Now I always try to include the TNM symptoms, because the swelling which you are dealing with may be a malignant one. Now this malignant one, you need to take positive or negative history of TNM, because your aim of history taking is not only to reach at a diagnosis but also to stage the disease if you are dealing with a malignant one. So T symptoms means what are the pressure effects which can happen with that swelling. Okay. So the site of the swelling is very important. If you have a swelling here in the neck, what are the pressure effects? You can have a pressure effect in your esophagus, you can have a pressure effect in your trachea or larynx, you can have pressure effect in the vessels. So if you have the vessels involved, pressure effect in the vessels, what will happen? You will have a puffy face, thoracic inlet syndrome. If you have pressure effect in your esophagus, there will be dysphagia. If you have pressure effect in the trachea, there will be problem in the respiratory system. All right. So these are the T symptoms. Then you inquire for N symptoms. Suppose a patient comes to you with a breast lump. You must inquire whether the patient is having any swelling in the axilla or not. You must ask the patient whether you have any swelling in the armpit or not. So that goes in favor of a N symptoms. That means if a patient with breast lump, only by asking from history, if the patient has a significant swelling, another swelling in the axilla, that means it is a locally advanced breast carcinoma. Am I clear? Now M symptoms. M symptoms means the metastatic symptoms. Usually metastatic symptoms will have by and large anorexia, asthenia, weakness and loss of weight. What is meant by a significant weight loss? Significant weight loss. Significant weight loss means more than 10% weight loss in 6 months. Okay, so that is what is known as significant weight loss. If the patient complains of significant anorexia means there is loss of appetite, asthenia, myalgia, weakness, and there is significant weight loss. That these are general symptoms of metastasis or a cancer. Okay, now you can have system specific metastasis. For breast cancer, it commonly metastasizes to the dorsolumbar vertebra. It metastasizes to lung and liver, okay, and brain also. So you need to inquire whether the patient is having any recent onset low back pain or not. If the patient complains of a recent onset low back pain, that gives you a hint that there might be some vertebral metastasis. Now you need to inquire in your history of present illness based on systems. If the patient has shortness of breath, hemoptysis, etc., then it goes in favor of a lung meds. If the patient has jaundice, yellowish discoloration, pain abdomen, upper abdominal pain, that goes in favor of a liver metastasis. Okay, so these are different M symptoms which you must include. So whenever you get a swelling anywhere in the body, take a history based on these parameters: number, site, onset, duration, progress, aggravating relieving factors, associated symptoms, recurrent symptom, or TNM symptoms. These are fixed for throughout your life. Okay, be it your undergraduate examination, be it your MS or DNB examination, be it your clinical practice. Now, in history of present illness, I told you the second point was positive and negative history. The first point was the elaboration of chief complaints, and third point is systemic history or systemic symptom evaluation. This we have already described. The symptoms related to GIT, gastrointestinal tract. What are those? The patient we divide the GI tract symptoms into 3 groups. One is the upper GI symptom, lower GI symptom, and hepatobiliary symptom. What are upper GI symptoms? It starts from dysphagia. Then the patient can have melena. Patient can have gastric outlet obstruction like symptoms, vomiting and etc. What are lower GI symptoms? Patient can have bleeding per rectum, hematochezia. Patient can have constipation. Patient can have pain abdomen, all these. Hepatobiliary symptoms: patient can have pain abdomen, right upper abdomen. Patient can have jaundice. Patient can have jaundice with fever and chill and rigors, which goes in favor of cholangitis. Am I clear? Next comes the genitourinary symptoms. Now in genitourinary symptoms, you have kidney, ureter, bladder, and in males you have prostate. So you have specific symptoms for each of these areas. There may be pain. Now, what is the typical pain of ureteric colic? That means a stone inside the ureter. It starts at loin, goes up to groin. So loin to groin pain indicates a genitourinary tract pain. There may be hematuria. That means presence of blood in the urine. This can be from kidney up to the urethral tip. Anywhere in this passage, the hematuria can occur. So usually from kidney it's a painless hematuria. You can have painful hematuria in downstream. All right. Now what are the bladder outlet symptoms? There may be urgency, frequency, nocturia, etc. So all these are genitourinary tract symptoms. Respiratory symptoms: shortness of breath, hemoptysis, etc., chest pain. CVS and CNS, cardiovascular system, the patient can have headache, palpitation, chest pain, and etc. CNS, usually in surgical cases, neurological symptoms are usually inquired for a brain metastasis. So in brain metastasis, what will you have? There will be headache, there will be vomiting, there will be some vision changes, and there will be loss of consciousness. There may be fall and convulsion. All right. So these are the important symptoms of a brain metastasis. Now coming to past history. Just don't write that there is nothing significant in past history. That is not done. So in past history, what you need to inquire? You need to inquire about whether the patient is a known patient of some major disease like tuberculosis, like diabetes, etc. Whether this patient has a same kind of disease in past or not. Okay. So there might be a recurrent pain. Chronic pancreatitis presents with pain for multiple times. Okay. So in past history you must include what is if the patient is having same kind of pain or same kind of symptom in past or not. Then you take any past major medical or surgical history. Okay, if the patient underwent appendectomy long back in at the age of 9 years, now he is 35 years, you must include that in this past history part. Okay, so important positive medical and surgical history, any known chronic comorbidities or chronic diseases he or she is suffering from, and same kind of history, same kind of disease in the past. So these are the things which you need to include in your past history. Then comes the personal history. In personal history, what we inquire, there are three parts of personal history. The number one is the personal things or the personal diseases or personal habits. They are included. In females, we need to include the menstrual history as well as the obstetric history. Now, what in personal history? Diet, addiction, sleep, appetite, bowel, bladder habit. Okay. Now, why diet is important? There are certain diseases which are common in vegetarians. There are certain diseases which are common in non-vegetarians. And intake of mutton, intake of red meat for a prolonged period of time will increase the chance of carcinoma colon. Now, intake of smoked fish and etc., salty food, too much intake of spicy and hot beverages will increase the chance of carcinoma stomach. Addiction, we all know addiction is very important. Now, what addiction you need to inquire? Mostly smoking or tobacco, then alcohol. These two are very important. Now, when you take history of smoking, it is important to note that what is the pack year of the patient. If the patient says I am a smoker, known smoker, now what is the pack year? You need to calculate and you need to write that in your history, that this patient gives a history of 20 or 30 pack year of smoking. Now, how do you calculate pack year? Number of packs per day into number of years smoking. Number of year of smoking. Okay. So number of packs per day, it's a 20 pack cigarette into number of years of smoking. This calculates the pack year. We call it pack year. This is very important, very often asked in your examination. All right. Sleep and appetite. You see, sleep and appetite is an indicator of a good sleep, is an indicator of a good well-being or healthy well-being. So there is some, if there is some disturbance in the sleep, patient feels pain during night, all these will indicate towards a particular disease of the patient. Recent loss of appetite, there is vomiting and etc. These are also important. Now, bowel and bladder habit, bowel, bladder, sleep, appetite. So bowel and bladder habit is very important because in recent onset bowel habit change can be a simple symptom of a carcinoma colon. So this bowel habit and bladder habit very important, not only for to diagnose the disease but also to see the grade and progress of the disease. Now socioeconomic status. Socioeconomic status is very important because there are certain diseases which are prevalent in lower socioeconomic group. There are certain diseases which are prevalent in higher socioeconomic group with sedentary lifestyle. Okay. Next is marital status, the status of children and spouse. These are also important. You need to write whether the patient is married or not. If married, whether the patient is having children or not. What is the status of the spouse? Are they healthy or not? Immunization you can include it in personal history. If you are taking a history of a child, then it's better to make a separate heading on immunization. Okay. If the patient is a female, then you need to include the menstrual history, menarche, cycle, duration, flow, last menstrual period, and if the patient is menopausal, then the menopause, age of menopause. These are very important, especially when you are dealing with some diseases which are having some hormonal predisposition, like a breast cancer. In breast cancer, you need to know this menstrual history. We know early menarche and late menopause, that is the total duration of exposure to estrogen, will increase the chance of carcinoma breast. Okay, so that is why this menstrual history is important. Obstetric history is important. Why? Because you need to know the number of pregnancies, abortion, whether they are preterm, number of living children, and age of first childbirth. This is again important because in nulliparous patient, breast carcinoma is common, and age at first childbirth is also important for breast carcinoma, because if the age is like less than 20, then the risk of breast carcinoma goes down. So these are important. How do you write? You write as a TPAL. Term pregnancy, preterm pregnancy, abortion, and living. That is how you write the parity of the patient. Okay. So in personal history, basically you have three parts. One is the personal information, diet, addiction, bowel, bladder, sleep, appetite, socioeconomic status, marital status, children and spouse, and immunization. If the patient is female, then you need to include the menstrual history as well as the obstetric history. Okay, so that completes our personal history. Then comes the family history. In family history, it is mandatory to write about the parents and the first degree relative. You just cannot write the family history is normal. So you need to inquire for same disease in family members, especially the first degree family members. Now, if you are suspecting as a diagnosis any kind of cancer, especially breast cancer, ovarian cancer, or a colorectal cancer, then it's better to draw a pedigree chart. All right, a pedigree chart. Now, you all know that breast cancer is now has a definite genetic predisposition in 10 to 15% of cases. So you need to identify whether the patient's family is having any genetic predisposition or not. So it's better to draw a pedigree chart. Okay, draw a pedigree chart, see how many members are affected by the disease or not. So you will try to basically ascertain whether your patient is having any genetic predisposition or not. Okay, either BRCA gene, or in colorectal cancers APC and other genes. Okay, so write in family history that the parents are doing well. If they are dead, what is the cause of death? Then you come to the siblings and other first degree relatives. What are they doing? What is the status of their health? If any of the family members, first degree family members, are not alive, then try to ask what is the cause of that death. Okay, so with this you can actually calculate whether your patient is having any genetic predisposition or not. Next, come to the treatment history. Now, treatment history is very important for the present disease as well as treatment for any previous illness. So major surgical history. As I told you, major surgical history you can include in past history as well as in treatment history. All right. So what is the treatment? Classically, the treatment history is defined as the treatment which patient has received for the present complaint. All right. So that is what is to be described in treatment history. Say for example, you are dealing with a CA breast and patient has received neoadjuvant chemotherapy. Now the patient is admitted for surgery. So by knowing this fact only, you can say I am dealing with a locally advanced breast cancer. Why locally advanced? Because when I'll take classes of individual cases, you will come to know that locally advanced breast carcinoma is treated with neoadjuvant chemotherapy first, then surgery is done. So see, by looking at the treatment history only, you can not only diagnose the case, you can also mention the stage of the patient. So this is very important. So treatment history includes the treatment which the patient has received for the present complaint or the present disease. You may include other previous treatment histories in the treatment history, but it's better to include them in past history. All right. Next comes the history of allergy. In case of children, you can include the immunization history here or drug history. Okay, allergy to any specific food or drug, this you need to include. All right. If you find the patient is allergic to any drug, actually you are going to convey this message, and in your BHT it will be written patient is allergic to this specific drug. Okay, so that is why history of allergy is very important. History of allergy to food, history of allergy to any drug, or history of allergy to any particular particle. Okay, so this basically completes your history taking. So again, just to recapitulate, your surgical case will be written like this. Start with history taking, general survey, local examination, systemic examination. These three are part of examination. We will be having another presentation on examination, general survey, local examination, and systemic examination. Then you write down your summary. Where you will mention all these points. After your summary, you give a provisional diagnosis. Then you give 1 or 2 or 3 differential diagnoses. Then you suggest some investigation. Write it down. So suggest some investigation based on which you will diagnose your case. You will establish your case. All right. So in history taking, again, what are the points you need to remember? And see, these are universal. You write this history in your undergraduate, you write the same history in your postgraduate as well as your postdoctoral or super specialty examination also. So first is patient particulars, then chief complaint, history of present illness, past history, family history, treatment history, history of allergy, immunization or drug history. In patient particulars, age, name, sex, address, occupation, religion, date of admission, date of examination, and MR number or bed number. All right. So that completes our history taking initial part. I am happy to take your comments, and if you have any query, write down a mail over here, or you can WhatsApp me at this number. We will be having several other classes starting from basic surgical skill, basic surgical history taking and clinical examination. We'll also be covering all the long cases which may appear in your undergraduate, postgraduate or super specialty examination. Thank you very much.